So today, what we're going to discuss is we are going to discuss what exactly is obesity and how do we measure it. It's a simple topic to start with. It seems very simple, but as you go to the nuances of it, you realize that's actually far more complex and far more nuanced than what we generally used to think. Now, what we understand as of now and what is universally accepted in terms of obesity is the measure of the obesity is the body mass index, the BMI. Now, BMI is a simple measure, that is the weight that you measure divided by height, which is square, right? So kg per meter square. That's the essentially what the BMI is. And it actually came in the 1830s when Quatlet first came up with what we call as the Quatlet index. It's a very simple measure which he came. That time, what he was trying to do was he was trying to develop a system where we could understand the proportions of a normal man. That's what he was trying to do. So 1830s was when it first came, right? And for almost 100 years, nobody really bothered about the BMI, right? So it went away until a physiologist called Ansel Keys resurrected this concept in 1972. He was trying to find again a way where in which he could conduct an epidemiological study to measure people, right? That's what he was trying to do in 1970s. And that's why he resurrected this concept and brought and called it a body mass index, BMI. The reason why he favored it was simple to measure. It was simplicity, which was the key. And that's the reason why it got a new lease of life. And what really pushed it forward was the American insurance industry. Now, what the insurance industry realized is that naturally somebody who is obese is more likely to develop more complications. And perhaps in that sense, probably the insurance premium should be higher. So they adopted what Ansel Keys really brought back from the dead, and they publicized it, they popularized it, and it became then the international measure for obesity. Probably there were better measures. Some of them were slightly more complicated. There continues to be better measures than BMI for sure. We'll see what are the issues with BMI. But BMI became the standard, and ultimately in 1990, it got adopted by the World Health Organization to define obesity. So that's the story of our beloved body mass index. And if you measure things just from the BMI perspective, there is a difference between what you use in the West and what you use in the East, that is for Indians and the South Asians. We'll see the difference. But essentially, if you take the Western cutoffs, somebody who has the BMI, remember, like I said, is weight divided by height in meters squared. Very simple formula to calculate. Somebody with a BMI of 18.5 to 25 is considered to be normal, healthy weight or healthy BMI. Less than 18.5 is considered underweight. Somebody who is 25 to 30 is considered overweight. This is Western standards. Somebody who is 30 to 35 is considered class 1 obesity. More than 35 to 40 is considered to be class 2. And more than 40 is considered to be class 3 or severe, or what is also known as morbid obesity. Now, again, the two cutoff points you have to understand is actually somewhere in the middle. So current guidelines, now we are going to discuss GLP-1 in the future or the anti-obesity medications in the future. The number you have to understand is 30. So anybody with a BMI more than 30 there is an indication for considering GLP-1 or any anti-obesity medication, or somebody with a BMI more than 27 with any complications attributable to obesity. We'll see which of these they are, will also be considered for therapy. But interestingly, and in Indians, for the longest time ever, we have been considering a slightly lower BMI to define obesity. Do you agree with that? What's your take on that? Because BMI is something you come across a lot in your fitness journey, and that's something day in, day out, your clients and a lot of people talk about. So what's your view on the BMI?
BMI is a great tool so far, but it is, I often see people miscalculate it, and sometimes they are not obese, and because of BMI, they find themselves into obese category. And so this is not a perfect tool, but a good tool to have.
Yeah, correct. So population perspective, it's very good because it's very easy, right? Something which is easy can be replicated very easily. In Indians, what the South Asian consensus typically says is that we'll discuss this point in great detail in the next few slides. Indians tend to have a higher risk at a lower BMI. threshold, right? So what they've done is they've lowered the cutoffs for BMI. So an Indian with a BMI of 18.5 to 23 or 22.9 is considered to be normal. 23 to 25 is considered to be overweight. 25 to 30 is now considered class. So if your BMI is more than 25, you are actually defined as obese. And if your BMI is more than 30, you are class 2 obesity. So you're anyways upgraded, right? So Indians, you have to use a lower cutoff value for defining BMI. So what remains low, of course, the guidelines still insist that the treatment should be based on the Western cutoff. Our risk factor is at a lower cut, right? We tend to have higher risk at the lower BMI cutoff, and we'll see the reasons why that is. Okay. So let me then give you two case scenarios. What these case scenarios will illustrate that why BMI alone is not sufficient to measure obesity. BMI is good, but BMI is not great, right? So we'll see the reasons why. Now, let's take two cases. Let's take case number one of Mamta. Okay, so Mamta is 48 years old. Her BMI 34, right? So if we go by both the Western standards as well as by the Indian standards, she will be considered obese. In both the cases, she is at the higher end of the obesity spectrum. So she is obese, no doubt about it, if you go by BMI standards. She's perimenopausal and has some vasomotor symptoms of menopause, but otherwise she's healthy. She's okay, right? She doesn't have any disease. She does not have pre-diabetes, diabetes, no cholesterol problems, dyslipidemia. She exercises and eats well, eats healthy. So clearly, Mamta is on a measuring device as obesity, pure based on numbers, but otherwise she's fine. She's healthy, right? She does not have a problem. Whereas, let's take the other case of Joginder. Joginder is 58. His BMI is also 30. Okay. His waist circumference is 112. We'll see the importance of that. He is already pre-diabetic with HbA1c of 6.2. He did an ultrasound recently where he was found to have a fatty liver. He has cholesterol problems. But what is the problem is that he had dyspnea. He has difficulty, he has breathlessness on walking. His echocardiography, when a cardiac echo was done, which shows ejection fraction, the pumping function is fine, but he has what is known as a diastolic dysfunction. He tends to get early morning headaches and he tends to feel sleepy during daytime, which is suggestive of what is known as obstructive sleep apnea. We discussed a little bit about sleep last time. He cannot exercise because he has a lot of knee joint pain. And he has bilateral swelling in the feet, bilateral edema, when you examine this Joginder, right? So Mamta and Joginder, right? Now, their gender, of course, is different. Their age is different. But at the same time, if you see purely from a perspective of BMI, both have the same BMI. But clearly, Chirag, I think it's very easy to recognize if what is these two, you have to prioritize one, right? In terms of whom you will give more time and more energy you will spend on helping them. Which of these two you will select?
Joginder, obviously.
Right? Without a doubt, right? So both Joginder and Mamta have BMI of 30. But clearly, Joginder is somebody who is more diseased with the same BMI, right? So he has more problems and hence needs a better care and probably needs treatment. So that's the difference between Joginder. So if you see the guideline, Chirag, that's the problem with numbers, right? In guideline, you just put them on guideline. BMI more than 30 becomes a candidate for anti-obesity medicine, right? But if I have to choose which of these two, then Joginder and Mamta are married with each other and they can only afford one of the two can afford a GLP. And probably Joginder is the one who should get GLP because clearly he is the one who is having more of a disease state. So that's the challenge. This again, what we're going to unwrap, how we can probably use better tools other than BMI for C, right? Now, recently, Lancet. So Lancet is one of the largest publications amongst the medical sphere. They came up with this new commission, which is called the Lancet Commission, where this is exactly the problem they tried to answer. That everybody, just based on the BMI, everybody is not the same. Literally, like I said last time as well, one size does not fit all. Right? That's the reality. Right? So if you see again, both Mamta and Joginder is shown in the picture. Mamta she exercises, she's healthy, she's happy. Joginder is not, right? So one of the two has to be prioritized, then probably Joginder gets the priority in terms of both the access to healthcare services with the fitness coaches, and also you will have Doctors, if you're doctors, you're listening to this, you will have to prioritize somebody in terms of treatment. If you're a fitness coach, you will again have to prioritize who you would give more time and energy. And again, somebody like Joginder should get more time, right? Now, so the difference is both have the same BMI, but clinically they are different people. Okay? So that's the problem with BMI. Now, the issues with BMI is, first of all, BMI is just a number. It's a risk marker, but it's not marker of people. And if you see what we discussed last time also and what we discussed in an earlier session as well, we need to understand that obesity is both a risk factor as well as obesity itself is a disease, right? And this is the key differentiation which you're going to see as we go along. Secondly, very interestingly, BMI cannot differentiate, and this is what Chirag was also saying. BMI cannot differentiate between distribution of BMI cannot differentiate between muscle mass and fat mass. It can't, right? It can just give you a number in terms of absolute weight. BMI tells us nothing about the potential disease state which the patient is having. So if you just give me a paper, she can say that Mamta is 34 and BMI and Joginder is 34 BMI. I cannot make a difference. I need to see them. I need to get more history, more details. Otherwise, just based on the number, I cannot differentiate who is at a worse state. And again, most importantly for Indians, is that BMI at different ethnicities should have different BMI cutoffs. But unfortunately, again, it's all universalized based on an American system, which probably does not, or a Western system, which probably does not fit the Indian setup. Chirag, have you seen people with a higher BMI who are otherwise healthy, probably don't need any help, just need a little bit of motivation? That's it. Like, do you see people like that?
Many people, even in athletes, we do see some people are like with a good height and good muscle mass, their BMI by calculations are very high, but they are not obese as such. And
They're not obese. So good. Absolutely. That's the difference. And that's the key difference you should need to understand. Now, why do you have to have different BMI for different ethnicity? And this is where a very important paradox comes into picture. We talked about Dr. Yajnik last time, if you remember. We talked about the fetal programming. I think Dr. Yajnik is the person who has redefined obesity. He did all this work in the 1980s and 90s, right? Way ahead of his time. Right? This is one man who was way ahead of his time. He published this iconic, literally an iconic picture in the Lancet, again, the same journal, many years back, which which has now become so popular, he called it as YY paradox. Now, just momentarily put this picture in your mind, right? And I'm going to tell you what it is. Now, on the left of me, you see the guy with the spectacles is a guy called Yudnik. This Yudnik is ethnically a Caucasian, a Russian origin. He was also working in the UK. And on the right, Dr. Yajnik, who is, of course, an Indian with an strong Indian ethnicity. Apparently, I had a breakfast with him once and he said, like, again, he brings closer to home. And he lives in Pune, works at KM. So these are the two people. What you again see is exactly what we saw with Joginder and Mamta. Both have exactly the same BMI, 22.3. So what Dr. Yajnik realized is that he is probably not as fit and healthy as his Caucasian colleague. So he wanted to know why. So what they did was they subjected both of themselves to a DEXA scan, and we'll see what the DEXA does. And they did a DEXA scan, and clearly it was found that Dr. Yajnik, again, had a body fat percentage of 21.2%, whereas Yudnik had a body fat percentage of 9%, right? So exactly the same BMI, right? But they have completely different body fat percentage. Chirag, do you see that difference, stark difference here? The Indian guy and the Caucasian guy. And again, if you have international platform, ethnically also they'll be different in terms of their overall structure.
that's what I was saying. No, with the muscle mass and everything, BMI calculation changes completely. If we compare with someone like person who is skinny fat in India to some muscular guy in other Caucasian like this city, it will be same, but health wise, both will be very different.
Exactly. You can clearly see that these two gentlemen, with exactly the same BMI. And again, BMI, which will you probably say normal BMI, right? Even then, you can clearly see that there is a difference in terms of the body fat. Because of this unfortunate Indian ethnicity, we tend to have that for swimming against the tide problem. Hence, we need to be even more mindful of the issue. He has a higher body fat percentage, whereas the Utnik does not have it, right? So this is what we call it as the YY paradox. So there was stuff of legends. It's still around. It's now got, again, just like the BMI, it's got a life of its own in the modern world where this body fat is become a very important aspect of management. Now, and hence, then let's move to this another concept, which is very important to understand. Interesting thing is that obesity in itself is a risk factor for other disease, but obesity itself is the risk. That's the paradox. That other paradox, which is also called the O paradox, right? So that, or an RR paradox, right? So it's a risk as well as it is the disease in itself, right? That's the interesting aspect of obesity, right? Now, obesity is a risk factor for other diseases like heart disease and diabetes. But in isolation, what we saw with Joginder had pre-diabetes and other things, but his main problem was obesity, right? So for him, obesity itself was the disease. So obesity itself can be considered both a risk factor as well as a disease. And that's what makes obesity very interesting. And that's why it's very important for, again, anybody in the fitness world to understand that are they dealing with somebody who is diseased because of its obesity or he's just having a risk factor. I'm not saying that both don't need management. Both need management, right? But in terms of prioritizing, in terms of considering for medication, somebody who has a disease state is more likely should be given medications. Now, the World Health Organization now clearly defines obesity as a disease, right? If you see, this is from the WHO website. It says overweight is a condition of excessive fat deposit. Obesity is a chronic complex disease defined by excessive fat deposits that can impair. So it's very clear that the highest authority or medical knowledge, the World Health Organization, now clearly defines obesity as a disease in itself, right? This is not new. It has been there for a while. Why it's important now? Because now you have, if there is a disease, there is a treatment. And now you have treatments which are very effective, and hence that treatment probably due consideration because of it. Right? So this is, again, to give you in terms of picture, risk versus problem or risk versus disease. So here you can see that there's a ditch there, and you put a warning saying that there is a manhole ahead. So that's basically risk, right? So somebody who gets a warning. So obesity, somebody who's not having disease, he gets a warning that I'm obese, I need to lose weight. Yes. But somebody who already has the problems because of they already fallen into that manhole, that person probably needs a rope to be rescued. And that's hence the difference, which is something we need to clearly see and define, right? So if we see Mamta and Joginder again, Mamta is risk, needs prophylactic care, needs to see a fitness coach, needs to work on her weight, but at the same time, probably is not the candidate for GLP or not a candidate for bariatric surgery or other things. But Joginder needs treatment now, probably yesterday, right? Is already there in the ditch. And apart from the care which is going to get in terms of the diet, lifestyle, and fitness, he also needs medications, right? So that's the essential idea which we need. We've seen this in other aspects of medical care. Like, for example, being HIV positive is a risk, whereas having AIDS is a disease, right? Having pre-diabetes is a risk. Diabetes itself is a disease. If you have high cholesterol, it's a risk factor. But having atherosclerosis, right, that is the deposition of cholesterol in your blood vessels, is the disease. So this differentiation has to be very clearly defined. Again, I'm saying that doesn't mean that you don't treat the risk factor, you treat the risk factor, but the priority is what we need to set and what we need to understand. So that is issue with these things, right? So, hey, what could be a strategy to subclassify and define these people? So that is what the Lancet Commission recently said, that you, instead of calling that both are obese, right? So if you clearly go by WHO definition, both are considered to be obese, but What you should say is that one is clinical obesity, other is preclinical obesity. So Joginder has clinical obesity, whereas Mamta has preclinical obesity. Both have obesity, but the difference is this, right? So what exactly, according to the Lancet Commission, which is now accepted worldwide, is clinical obesity? Who is the person who had obesity as a disease? So first of all, they should fulfill the BMI criteria, which we saw for a Western person would be 30 and for an Indian would be 25. Fulfills one measure of central adiposity, and I'll tell you the importance of that in a few minutes, plus has some disease or organ dysfunction because of obesity. For example, you saw in Joginder, he had pre-diabetes, he has obstructive sleep apnea, he has what is known as heart failure with preserved erection fraction, he has all these problems. So he has a high BMI, he has the waist circumference, which is 112, which is considered to be high, and has some disease state because of the problem, and hence Joginder fit into clinical obesity, whereas Mamta just has BMI, which is high, but does not have the other situations, and hence she would not be considered as having clinical obesity, but would be considered having a preclinical obesity. Okay. Now, you would say, what are the diseases caused by obesity themselves? So, obesity itself can lead to a lot of problems, and from head to toe, and you would have seen this, I mean, a lot of your clients and a lot of in your patients and clients would have seen this. If you start from the top, people who are obese tend to have recurrent headache, sometimes can have vision loss. They have a condition called range intracranial tension, which can cause severe headaches. So somebody who is overweight or obese can have headaches just because of their obesity. And we have seen number of people who has come and told us after their lost weight that one unintentional consequence which has happened is that my headaches are gone, right? So that big a problem. Some of these people have what is known as obstructive sleep apnea. That is, they have difficulty during the sleep, often gets disturbed minutely, and hence they feel very tired during daytime. They can have respiratory problems. There is a condition called Pickwickian syndrome, which comes from a very famous story. And you tell me what story that is. Pickwickian syndrome comes from a guy called Pickwick in that story, who basically, because of his overweight, had breathing problems. So that is a issue which can happen. Obesity itself can lead to what is known as heart failure with reserved ejection fraction, where your pumping function is normal, ejection fraction is normal, but you still have a heart disease. It can lead to fatty liver, which we saw. You can have recurrent urinary infections, and you can have urinary incontinence also. So if you have seen a lot of your obese people, you tend to have problems because of that. You could have some of these people, women will have PCOS. Men can have hypogonadism. We discussed last time that obesity itself can lead to reduction in the testosterone levels and can lead to infertility in both men and women. Obesity itself can lead to knee joint osteoarthritis. It limits your daily function, and some of these people have swelling of their, right? So this is how obesity can impact the problems which people face in their lives. Chirag, any of these things in your clients? Do they have any of these disease states come with this?
So commonly we see sleep apnea happening.
Yes.
That is a very common obstruction, especially typically that they're not able to breathe properly while they sleep. And
Yeah.
few of them got there is a device for sleep apnea. Doc prescribed them that.
Yes.
Other thing, productive problems are definitely there. Maximum queries from gynecologist and client referrals from there that if someone is planning to conceive, they should first get out of the obesity. They should try to fix that thing. So these are the two most common things which we see among our clients.
Sure. Yes. What you're seeing is that obesity in itself, again, would get a referral itself because in fact, we in fact get a lot of referrals from IVF fertility specialists to say that this patient needs to lose weight. We're just referring this to you just for the weight loss aspect. And that is also something which has now become a very important area in terms of the clinical management. So we already did this, right? But does this hold true for Indians? And that's the end of the day, that's the important question. So this is exactly what Dr. Anup Mishra talked about. So Dr. Anup Mishra is a very senior physician and based in Fortis, Delhi, and he's again a pioneer in this field. What he said is, in fact, as a corollary to the Lancet paper, I think he was part of the Lancet commission as well, as I understand, but he wrote a paper completely separate to this, saying, defining the same thing for Indians. And what he did is made it very simple. So, if there's one message you need to take home, and one number you need to remember, or one slide you need to keep in your mind. This is slide. What he said kept it very simple. If your BMI is more than 23, and he brought it down from 25 to 20, right? He said if your BMI is more than 23, with any measure of central adiposity, right? So basically take the BMI with measure of central adiposity, with that is basically obesity. But if you have any disease along with that, it is stage 2 obesity. If you don't have a disease along with that, you have stage 1. Simple, right? So simple to keep in mind. Now, this is where this central adiposity issue really comes into picture. What is important, right? To understand, and we'll discuss central adiposity in the next upcoming slide because it's very important. What science has told us is that fat basically, where your fat is as important as how much you're fat. Now, last time or some time earlier, I told you about sumo wrestlers. So sumo wrestlers actually look very obese, but they're not that unhealthy. They actually athletes themselves. Fitness is pretty good. They can actually run faster than not us can. So sumo wrestlers tend to have a lot of subcutaneous fat, but they tend to have less of visceral fat. Okay. So more of subcutaneous and less of visceral fat. And more of subcutaneous fat. So if you have fat beneath your skin, that generally leads to less problems than fat which is there in the central part, right? So if your fat is there in the visceral part, that is more of a problem than fat which is there underneath your skin. So the subcutaneous is less problem than the central fat which is within your body, which is known as visceral fat, because it's visceral fat is directly linked with disease state, right? All the diseases that you see are because of visceral fat. Okay. Now, you can't measure visceral fat from outside. So one indirect way of measuring visceral fat is measuring the waist, right? So waist circumference is something which is a very simple but very effective measure of indirectly measuring visceral fat. And hence, waist circumference plays a very vital role for measuring obesity, especially in Indian population, because we tend to have less of subcutaneous fat. We are exactly opposite of the sumo wrestler. We have more of visceral fat and less of subcutaneous. So we look thin, but we are actually worse, right? Your take on this?
Just like I told a few minutes ago about the skinny fat situation, this is what we see outside in the population. Like your entire body is thin. You will be wearing small size or medium size clothes, but your belly, all the fat is in belly and around the waist.
Okay. So it's a belly fat. So the belly fat is the one which is the problematic fat. So idea is that if you could add the central belly fat as an important measure of the entire system, that would enrich the diagnosis of obesity and that will give more value. So what are the ways in which you could do? Of course, measure the BMI. Along with that, you measure the waist circumference, or you could measure something, a very simple measure called the waist to height ratio. We'll come to that. You can measure something called as the body roundness index, which recently there are a lot of papers based on that. Or you could do something more advanced like a body impedance analysis or a DEXA scan, right? So we'll come to all of these points in a minute. Now, the simplest thing to do is to measure the waist circumference, right? So you can see here from Dr. Anup Mishra's paper, doctor who is measuring the waist circumference, you require simple inch tape, right? You all have it. Just measure that, right, at the central part. Now, if the waist circumference is more than 90 centimeters in men, and these are cutoffs for Indians. Okay, there's a different cutoff for Westerner. Let's forget, apne ko kya lena dena Westerners, apna dekh, right? So, Indians ke liye, if your waist circumference is more than 90 centimeters, it is considered to be high. More than 80 centimeters in 90 centimeters in men, more than 80 centimeters in women, that is considered to be higher. And so if you have BMI, which is more than 23, with this, you are fit to have obesity, according to Dr. Anup Mishra and according to what now is fast being accepted across the country. So that is the key aspect in terms of the weight, right? Now, another good way of measuring weight of the central adiposity is what is known as waist to height ratio. Very simple to use and very simple to calculate. And in fact, recently in the whole European Congress, this is what was very largely discussed. Right. So weight to height ratio में क्या करना है? Simple चीज करनी है. You measure the height in centimeters or meters and measure the waist circumference in centimeters or meters. Right. Now, waist circumference divided by height. Right. So if your waist circumference is more than half of your height, more than half of your height. So let's say your height is 180 centimeters, and if your waist circumference is 95, you are obese. Right. Simple measure है, बहुत complicated नहीं है. If again I'll repeat, if your height is 180 centimeters and your waist circumference is 95, 95 divided by 180 is definitely more than 0.5. So anything more than 90, right? So if your waist circumference is more than 90, height is 180 centimeters, simply you are said to be obese. Or not only are you obese, but you have central adiposity, you have a problematic obesity. So what, the Europeans also, European Obesity Congress said, and what we also starting to adapt is that BMI is a very simple concept, but this is the concept which is far better and simpler than BMI, and also equally easy to calculate in terms of a measurement, right? So what in future we should insist is measuring the device, right? So this way of doing it, right? Now, so what I'd suggest, then Chirag, do you measure the waist circumference in your life, that, or should you consider doing that? Would you consider doing this?
The app we are using currently, our own app, in that we always ask them to enter their waist and height, everything, so that we at the back end we can see the waist to this height to waist circumference and check if the client is in obesity or not.
Dr. Gupta, sir, I think we'll answer your question. I put in a lot of questions. We can just hold on for a few minutes. We'll allow you to unmute at the end and ask your questions. A little distracting as of now. We'll come to your questions in a bit. So just can you hold on for a minute or two? Okay. We'll allow you to unmute and ask in the end. So you can ask in person. Okay. So if you could give us a few minutes, let us just finish the formal presentation. Now, more advanced gadgety tool, somebody into technology, but something which is considered gold standard is actually to use a DEXA machine, right? Now, a lot of doctors would have seen a DEXA machine, and doctors often use DEXA machine, Chirag, mainly for measuring the bones, osteoporosis, right? So it's mainly used for that. But a lot of doctors don't know that the same DEXA machine, all you need is another software, which can actually tell you far more important use, especially in today's world where obesity is as important as osteoporosis. It can actually give you a lot of data, which is considered to be gold standard in terms of the data. So this is, I taken a DEXA report from the company's website. Right? This is a sample data which they've given us. So here you can see there's a lot of data you can get, right? So again, you probably, for geeks who are into this data, you can get so much rich data from that. Just to give you a glimpse of the entire thing, you can see here, it can tell you a lot of indices. You can clearly see the whole body, you can see the body fat percentage, but you can find area-wise distribution also, right? So you can tell you fat mass divided by height square. We'll see the importance of bounded indices. Lean body mass divided by, you can actually measure the lean body also with this. The lean body is the actual body minus the fat, right? It's the weight minus the fat, the visceral fat, the sort of the total fat percentage. It can tell you the visceral fat also, you can see here. You can tell you the android and gynoid ratios also. So when we some of the important matrix which you can get from this. But overall, the first metric that you have is the overall body fat percentage. And for men, a body fat percentage more than 25 is considered to be high, and more than 35 in females is considered to be high in females. So this is the body fat percentage which is high. Use DEXA. I've seen these reports. Your patients bring the reports.
Yeah, and also just for the audience, DEXA is a kind of low dosage X-ray machine. X-ray, I would say, and it costs somewhere around 1,400 to 4,000 rupees. Just search on Google. There might be a DEXA facility nearby to your location. Get it checked once. You will get to understand how much detail we get in that.
Yeah, absolutely. So it gives you a lot of details. In fact, good part is it actually all of these patients can track their progress also over a period of time. But of course, remember, it's like an X-ray. So there will be some radiation exposure, but it's a very low dose X-ray. And what we generally do is, especially for all the patients who are really interested, you can do it at an annual basis. Don't do it very frequently. Do it maybe once or twice, once a year, or maybe once every 2 to 3 years. That's a good idea of being had. especially if you're into any kind of research or any kind of knowledge into that. So we already talked about the body fat percentage, but there are a couple of more indices which are very interesting and which are very important. So one is called the fat mass by height square. You see here in the data, we can see this fat mass by height square as a data point. Again, I'm just going to tell you some data points and see if what could be useful to you. In men, less than 8.3 is considered to be normal, and women more than less than 11.8 is considered to be normal. So this is one very important thing. But a little old, but it still has clinical significance. It's known as the android-gynoid ratio. That is, it should be less than 1 in both the genders. So you can see again, you will find that ratio here by the android value, fat percentage in the gynoid. And the gynoid should be more than android in most cases. Android is the central fat, and this gynoid is the hip fat. Right. So hip fat is generally considered to be safer compared to the belly fat. Right. So the belly fat, if it is higher, that's a problem, both in men and women. Right. So again, if you have this ratio less than 1, it is considered to be. You can also measure the trunk versus limb fat, right? So this could be in some of your people, it could be very useful. And if this value is more than 2.6, there's a study which has shown that these people have higher risk of developing diabetes. So there's a lot of interesting areas. You can actually measure the visceral adiposity. Like I said, this is the bag fat, right? It's the actual bag fat which is there. There are various metrics to measure this, and less than 500 is considered to be normal. But more than 1 kg of visceral fat is considered to be people having metabolic syndrome tend to have these values. Again, you could look at the VAT volume, and you can also look at the VAT area. But the mass is the one which is the most popular and very easily acceptable by a lot of these people. Right. So that these are the things, right? Now, another two, we'll put this calculator up on the technopriority.com. We made this calculator. It's called the body roundness index. It's a little complex calculation. I put the link also below. You can check it out. That's available on this link, but we'll put it up. Body roundness index actually uses a slightly more complicated formula, but you require some simple measures to basically just need to see the patient's height and the weight. So the same data which you collect for other things, just need to enter this data, and this calculation actually tells you now why this is important. Because recently there were a lot of studies which are done with body roundness index, which was now shown that a certain body round index on the higher end is linked with higher risk of cardiovascular problems and death. Right. So somebody with a body roundness index of more than 10, he or she has very high risk of developing heart related complications. So I think if somebody asks you what are the matrix which are better than BMI, BRI is a very useful and very important matrix, which could be because it is directly with risk of complications. And that's why you tend to have higher priority to these values. And again, the complex calculation is a little complex, but the things you are measuring is very simple, right? So just a couple of things you have to take, put it up in a calculator, and you'll get the results. And we also, what we've done in this calculator which you have made, we also given you the interpretation of that. So you just calculate it and you'll tell you the interpretation, right? So you can check it out free of charge, right? It's available free, right? It will also tell you the risk associated with that. Again, something, try doing it for yourself, try measuring these things for yourself, and you'll also get where do you stand in terms of overall health. So that's interesting. Do you find any of these values to be used? In your
Yeah.
case? And what kind of measurements you do in your clients?
So we generally prefer DEXA scans on priority. Otherwise, we just ask our clients to get the body fat percentage calculated through body composition analysis scales and all, in body scales and all those things. If clients are not able to do that, then we ask simply their waist to height ratios and other their body images so that we can gauge the condition of their obesity.
And in the world of I think as you're more evolving, we could have very soon there will be models where you just have to take the patient's photograph. And you might be able to estimate some of the data also right on that. So I think that's also where we are moving towards. But of course, that's still to be tested. Now you talked about this. Right? This is called the Bioelectrical Impedance Analyzer, right? So a lot of you would have seen this in the gyms and also a lot of obesity centers also. Like Chirag said, is a very popular company. InBody is a company actually. So InBody is a popular company which makes this device. So body impedance analyzer is you just stand on the machine, it will pass a small electric current. It gives you the similar data which you get from DEXA. A couple of caveats here I just have to say. First and foremost, the bioelectrical impedance analyzer BI is available. If you see on Amazon, there are hundreds of companies making. There are some which are cheap, right, which cost very little, versus InBody which cost in lakhs, literally, right? So there is a big difference in terms of the quality and accuracy of these devices. The cheaper end devices are not accurate, right? In fact, if you look at the data from that, in fact, you would not get reliable data. It's whereas the in body, the flagship actually gives you very high quality data, which there are now several studies, including studies from India, where they show that in body calculations are as close as possible to DEXA value, right? So it's a very, and unlike DEXA, you actually are giving some radiation exposure. Here, there is no radiation exposure. There's a small electric current that passes through you. And again, in terms of the BI, what they found is that the body fat percentage typically, what they measure in Indians tend to be more than 25, tend to have 36 as the body fat percentage to where from BI. And similarly, they compared with DEXA, which is 39. So it was close to, and it was not statistically significant in terms of the difference. So it tends to be very accurate in terms of this value. Now, your experience with this in body measures.
Yeah. Just to let everyone know, in body scales, the brand in body or similar scales comes around 1.5 or 2 lakhs.
Yes.
And nowadays on Amazon, you will see smart scales selling for like 2000 rupees, 900 rupees. Don't assume they are accurate. They are not at all accurate and they will give you false reading. And false can stress you more. You won't rely on those scales, those cheap scales. If you have an in-body center or any, for example, any BLCC center, Gold's Gym nearby or Anytime Fitness, every big chain have these machines. Go there, pay some amount, they will be allowing you to measure your body fat percentage. That is the best way to do.
Correct. Right. Absolutely. So again, be careful of the machine that you use. And like Chirag said, it could be something very cheap compared to, and you might get the wrong result. With this, we end the measurement. I'll just to tell you some important take-home messages that we learned, and then we'll take your audience questions as well. I will have a sort of a more free chat now. But just to summarize a couple of things that we have to take. The first and foremost, what you need to understand is that obesity has two things. Obesity is a risk factor as well as the disease itself. And when you have a patient or a client with you, you need to understand the difference of it, right? So you need to understand whether somebody who is obese is fat, is having a disease, or is he or she having a risk factor. So that's one thing which you have to be very clear about. Secondly, we talked about BMI and we saw the cutoffs for BMI for defining obesity, but we saw the problems with BMI. Also, very important, we discussed about the central, right? So central adiposity is a very useful and important tool, right? So there are ways of measuring central adiposity. Split is to measure the waist circumference, but there are other ways of doing it, like the body roundness index and the waist to height ratio, which is again a very simple calculation. There are more advanced tools like the BI and the DEXAs, which you can use if you have the facility available. It will give you more data, give you more information about it. And finally, just to reiterate the fact, how do you define obesity in Indians in 2025? You do it as per what Dr. Anup Mishra said. Take the BMI more than 23 with a measure of central adiposity, which is high. So the patient has BMI of 23, let me say a waist circumference of a male with a BMI of 24, with a waist circumference of 95, he is defined as obese. So he's stage 1 obese. But somebody with a problem associated with obesity, like maybe an arthritis or a fatty liver or a sleep apnea, will be considered stage 2 obesity. So that's how we define obesity in India, current status, and that is the one which you should be probably considered. Right? So with this, we end today's talk. We'll take the questions, and before that, Chirag, your comments and your thoughts.
I think we can go ahead and take questions first.
Okay. Yes. So I think Dr. Ajay Gupta, sir, if you're there, you have quite a few questions. If you could just directly ask, we'll unmute, we'll allow you to talk. And sir, can you please go ahead and ask directly? Yeah. Meanwhile, we will take some of the questions which, yeah. Okay. Anonymous attendee has asked how to treat childhood obesity. Okay, we'll discuss about treatment at a later date. So right now we're just discussing defining the problem. So we'll discuss the treatment aspects at a later time. Okay, Sana has asked, Vitalo weight machines. I'm not heard of it. Like, have you heard of that particular company? Maybe we can check with the data. So we're not aware about a particular machine.
I think
Yes.
Sana, I meant to ask about Fitalo. Fitalo company, there is a weight loss company out there. Maybe they are selling some sort of weight
Yeah.
machine.
So again, Sana, we are not aware of that particular machine, so it's difficult to say. I think we talked about, as asked about the body fat distribution. So the area-wise distribution, that not all of the parameters have been tested in clinical scenario, but that we talked about a few parameters which are we, but you can find more data about the individual parameters also. Yeah, Dr. Ajay Gupta has asked about hand grip strength. Yes, so hand grip strength is a very useful measure of your overall muscle strength, especially in terms of when you're trying to define, especially in older people, when you're trying to define sarcopenia and other things. So that could be a very useful tool. Chirag, you measure hand grip strength and other measures of the muscle. How do you assess some of these people in terms of their muscle strength?
Not the hand grip, but we generally ask people that they should aim at least to those squats at their body weight, equals to their body weight, along with the bench press and along with the deadlifts as well. That's a very good measure that you have enough strength in your body.
Okay, great. Yeah, I think then you have a lot of questions, comments from Dr. Ajay Gupta. Gupta, sir, if you could ask them directly, that will be good because there's a combination of questions as well as some points that you have put for discussion. So if you could, we already allowed you to unmute, so you can probably come and ask, what online, so that we could. Yeah, anybody wants to mute and ask directly, would be happy to take such questions. So I think we don't have any more questions. I see that chat. Yeah, Sunrise says arms, thighs are heavy, other parts are okay. What could be the reason? Yeah, there are conditions where the body fat distribution is often different in a lot of people. There are clinical conditions called lipodystrophies, where there could be a very unusual fat distributions which could be there. You might come across some of these people in your practice. And again, if you see such a person, it would be a good idea to then refer to an endocrinologist, right? They'll be able to help in a more effective manner. Okay, Dr. Sumeta has raised her hand. Yes, please go ahead.
Good evening, Mr. Lapani. Sir, I just want to know, doctor, that how we can actually see hip waist hip ratio clinically related and how we can modify whether it will the reduction in the inches will be first seen.
Yeah, so it would depend on person to person. Everybody does not, just like they don't gain the fat in the same way, they do not lose the fat also in the same way. So some people tend to lose the waist circumference faster. But overall, it is very difficult to predict what the area where the weight loss will happen first. It cannot be predicted in that sense. It is often genetically determined and defined by a lot of other factors as well. So what our overall idea would be to lose weight in total. And that kind of reduces all the parameters. So I think that's the broad sense. But yeah, Chirag, any
This
comments
is
on
the
that?
most common query we get among clients as well. They always come with that similar, but that's not how it happens. You have to lose fat from all over your
Yeah.
body, and we are not sure which body part will lose the fat first. Sometimes you will start losing your chin fat, this area, sometimes
Mm.
this area, sometimes under your arms. So you have to lose the overall fat only. That's the only solution.
Got it. Thanks. Thank
Yeah,
you.
great question. Great question. So again, frequently asked questions. Syed has asked a very interesting question. Is there a relationship between obesity and mental health, including depression and anxiety disorder? Very good question. I think yes, answer is absolutely yes. There are multiple ways in which there is a relation. There's a bi-directional relation. So again, obesity can itself lead to mental health problems, whereas mental health problems can also lead to obesity. We discussed last time also, medications that have been prescribed for mental health issues also can lead to weight gain. So there is a direct bidirectional relationship. I think Chirag, we discussed that a bit last time. Your take on the mental health aspect and weight.
Yeah, so one of the major issues along with the obesity comes with the self-image issues. Self-image issues is one of the major and most common factor where people goes into the depression and start facing anxiety because of the social and the society causes.
Yes. So Dr. Mohammed has asked, isn't waist to height ratio better measure? Yeah, exactly. So that's what we're trying to say. And BMI alone is not enough, and measuring these central adiposity parameters are great. Right? Okay. I think Sana's question we had answered. Okay. Dr. Parameshwari Subramaniam has asked, a 6-minute walk test plus hand grip, it's a better marker of cardiac health. Yeah, it is correct. As a 6-minute walk test is a great tool for looking at the patient's fitness overall. And do you do some sort of a baseline fitness analysis, Chirag, when a new client walks in? What are the things you do for the first early meetings when they start in that journey?
To do certain activities where we check them how many jumps they can do, how many minutes they can stand on there without moving their body, and how much they can walk. These types of tests.
We could probably in future develop some sort of a great SOP where it's a good area where you could probably do some baseline assessments in both in terms of matrix as well as in terms of their clinical segment as well. I think that could be a great idea. So thanks. I think that could really work in terms of 6-minute walk test. Of course, we do it. It's a standard care, but maybe use other parameters also to judge somebody's fitness. It has asked, should body mass analyzers be used in professional doctors' clinics? So yeah, we do use them in our own hospital. We have in body. So we have that available, and it's a different question whether the doctor has the time to look at those reports. That's a different problem, but we do have these available now. So at least hospitals have it, right? Yeah. So yeah, these were some of the questions. Yes, I think somebody has also raised their hand. Yeah, Niti Agrawal, please go ahead. And this is the last question we'll be taking, and then we'll break for we'll have the next session. We'll take it. Yes, Niti, please.
Good evening, Dr. Lakhani. I have two questions. So my first question is, let's say if there is a person, obese person, and that person loses the weight completely, right, in a very good state. Now the skin hangs, right? There is a sagging of the skin. So
Yeah.
in that prospect, which will be the best method, which would be the best method to assess their fat percentage?
Yes. Yeah, the method still remains the same. But again, what you said, I think that it's a very important problem, especially in this today's era where you're going to have a lot of people lose or weight a lot of. See, just a few points I'll tell you about this, and this, like it's a very common problem. If somebody loses fat faster, that hanging of the skin and all that becomes a bigger problem. So if you lose it more gradually, your body also has more time to adapt. Secondly, as far as the measurement is concerned, measurement essentially does not change much. But again, if you want more detailed analysis, then in that case, again, a DEXA would be that ideal setup, especially if you're looking at all these kinds of skin hanging and or abnormal fat distributions or all that, we'll actually get a much more detailed view from the DEXA. So I think that would be the more accurate way of measuring. But sometimes accuracy in these cases is less important, and sometimes these people have more of a problem of a cosmetic disfigurement, right? Where in which case a good consultation with a good plastic or a cosmetic surgeon would be a good idea in such patients. So again, for these patients where we anticipate this to be a problem, especially those who are about to undergo bariatric surgery, we often keep bariatric plastic surgery also in the loop, especially if they have essentially cosmetic issues. Let's say they are public figures and they need to be more presentable. We tend to keep a cosmetic surgeon also in the loop. Chirag, your take on this? It's an important problem.
DEXA scan is the perfect answer to that. That will give us the better breakdown of the fat in the body. Plus, always consult a surgeon. I always tell these people that if once you get a lot of loose skin, there is no way to remove it.
Yeah.
Just the diet and exercise. It's better to consult a cosmetic surgeon or plastic surgeon. They will guide you better.
Yes. All right. You
Thank-
said you another question.
Thank you so much. Yes, I have another question.
Yes.
So it cropped up in my mind when right now we spoke about depression and eating habits and it affects. So now today I met a psychiatrist and he happens to tell me that when we go on a journey where the depression is being treated, people start to eat more. So I asked him, and then people gain weight. That becomes very depressing. So I asked him, like, why it happened. He says it's a part of the recovery process where the brain gets relaxed, and then you tend to eat during that time. And it should eventually get better, and that craving for sweet, and it subsides. So I want to know your take on it.
As we again discussed last time, there is a system in the body which actually gives you pleasure when you eat, and sometimes, especially people who have depression, actually lose that as well, right? They lose that pleasure from routine things like eating, right? Routine things like maybe going for an exercise that gets cut off, which is quite a problem because the common things which everybody gets pleasure from, right? They don't get it from. And like your psychiatrist said very rightly, that once that recovery process starts, that relinking of pleasure that you get from food, pleasure that you get from your day-to-day routine stuff, like hanging out with your friends, talking to your family, spending time with your children, that starts returning back, which is again, I think it's a great sign of recovery as well. So yeah, there would be a tendency to gain weight. I think people with severe depression, I think we need to work in a more tactful way where the weight loss aspect also is taken care of and their journey to recovery towards pleasurable eating also is returned. But having said that, I think one thing is very essential, that what we need to understand is you can still eat healthy, right? You get a lot of pleasure, your appetite has returned back and you're feeling better and you're eating because of that. You could still choose healthier, and that also helps. Sometimes also again a caveat here, some of the medicines which are given for depression will also have these kind of effects. So again, whether this is the patient themselves or whether it's the effect of medication, also that is also something which has to be kept in back of the mind. But yeah, that's a great, interesting question. And I think I probably take it from case to case basis. But again, what you generally recommend is that yes, you are going to a recovery side, but you could still choose healthier eating. Your take.
So whenever you are on antidepressants, you might feel like eating more because some people feel their life is getting back. They should be able to enjoy now. They should be able to feel the pleasure coming from the food. And it's a very common thing, I think, to judge people on that. But I always advise people, this is the best time you should be having a coach or someone to look on you, to keep you on track, to again and again remind you that you are losing the track. You should enjoy the food, but in a very limited moderation, so that it doesn't become a cycle. Otherwise, you will get stuck in that cycle because of antidepressants. Because you will end up gaining it, and again you will go in depression. Again, antidepressant. It will become a cycle.
Yes. Great
Oh,
point.
thank you so
So
much.
thank you, Nidhi. Those are great questions. So I think we can end here. We'll be coming back next week with let's go to treatment, right? So Chirag, what we'll just do is next week we'll discuss the fitness and the nutrition, right? So I think the core of essentially of weight management. So lifestyle measures is what we're going to discuss next time. And Chirag, you'll be leading the way there. So we'll meet you on next week. We'll have the next session next Tuesday. And meanwhile, you can go back and have a review of today's videos as well on technology.com. Just check it out there. So yeah, that's all for today. Anything else, Sheila, to add?
Next week, I'll be mostly guiding all of you about how to make a diet for yourself, how
Yeah.
to make a workout program for yourself, so that you guys can start it right from the next day, or maybe start applying on your clients. That will be really useful to you.
Great. So great. So looking forward to the next session next week. And yeah, thank you all for being part of this. And I think, it was a great attendance. And thank you all for interacting as well. Yeah. And yeah. Right. So we'll see you next week. Thank you.
Thank
Good
you.
night.
Good night.
Good night.